So, good evening, everyone. Welcome to our this month's POWWOW. We have reached our POWWOW number 15. This month's discussion will be on oculoplasty. I would like to invite our moderator, Dr. Mritika ma'am, to take over and introduce our speakers. Over to you, ma'am.
A very good evening to all. It's my pleasure to introduce two very young and dynamic oculoplasty surgeons to present two very interesting cases today in POWWOW. We have with us Dr. Parinita Singh. She's a consultant oculoplasty at Devi Eye Hospital and Bangalore Baptist Hospital in Bangalore. And we also have Dr. Shebin Salim. She's a consultant oculoplasty at Giridhar Eye Hospital in Kerala. And we welcome you all. And I would also like to welcome our expert panelist for today's POWWOW. We have Dr. Preeti Uday, who's the director and head of oculoplasty at DRR Eye Hospital as well as Agarwal Eye Hospital in Chennai. And we have Dr. Vatsalya Vijay. She's the consultant oculoplasty and orbit at Goa Medical College. And we have our in-house very own Dr. Bipasha Mukherjee. She's the department head and director of Orbit, Oculoplasty, Reconstructive and Aesthetic Services of Shankar Nethralaya, as well as she's currently a consultant. She's also a consultant at NMC Specialty Hospital at Abu Dhabi. And we have with us Dr. Muhammad Shahid Alam, the Deputy Director of Orbit, Oculoplasty, Reconstructive and Aesthetic Services, Shankar Nethralaya, and all academics at Shankar Nethralaya, Kolkata. We welcome you all, and I hope we have a very interesting session. Should we go ahead with the first presentation then?
First of all, a very good morning to everyone who could join us this evening, my mentors, my teachers, and all the fellows. I'm very thankful to Dr. Varsha and the entire SN team for giving me this opportunity. Today, I'm going to present a case that is entitled Mess of a Mesh. So this 22-year-old young gentleman presented to me with the chief complaint of double vision when he looked towards the right and in down gaze, and he was not happy with the appearance of his right eye. There was a history of road traffic accident followed by fracture repair done 5 weeks ago. So as we can see, there was a subciliary incision that was taken for the fracture repair that had healed. Along with that, there was lower lid retraction and upper lid retraction. The best corrected vision in both the eyes was normal. The intraocular pressure was normal. There was a 2 millimeter inophthalmos in the right eye, lower and upper lid retraction along with lag of thalmus. And in the extraocular movements, there was a limitation in the depression and abduction in the right eye. So an inophthalmos, a mild one, and there was lag of thalmus. Extraocular movements, limitation in depression and abduction in the right eye. So in the OPD, I did a forced duction test under topical anesthesia, and I could feel that there was a slight limitation in upgaze. So in the CT scan, we could see that there was an implant that was placed to repair the floor. And I saw that the inferior rectus looked a little bit deformed. And also it was seen abutting the implant. So we went ahead and did a dynamic MRI, which showed a deformed right inferior rectus abutting the implant in primary gaze elevation and in superotemporal gaze. So I thought I'll discuss the case with the operating surgeon, and I found out that due to lack of funds on the patient's end, an implant that was used to repair basically for cranioplasties was used in this case. It was cut to the shape of the orbital floor defect, and it was used for the fracture repair. Then I realized that on CT scan, I could see in the fracture, in the orbital implant, I could see large holes. So that correlated. So we thought that this probably the mesh is the culprit over here, and we went ahead to remove the mesh. So in the surgery, we noted some amount of fibrosis around the mesh. The plate was removed and it was replaced with a pre-contoured orbital implant. A forced duction test was performed at the end of the surgery and it was free. Post-operative 1 week, the patient still complained of diplopia and there was limitation in extraocular movements. Post-operative 4 weeks, now the diplopia had reduced and extraocular movements had improved. A post-op CT scan looked fairly okay with the implant well placed. Fast forward to post-operative 8 months. Now at this point of time, the patient no diplopia, the extraocular movements were full, and the lid retraction had also improved quite a lot. So this is currently how he is, and this is how he had presented. So we can see there is improvement in the lid retraction. The in-ophthalmos is also better, and obviously the lag of thalamus has improved. So orbital fracture, the theories that are implicated are bone conduction theory, which states that when the blunt force is transmitted through the orbital rim, the weakest point of the orbit gives way, and that is how the fracture occurs. The hydraulic theory states that there is a rise in intraorbital pressure, which ultimately gives way and the blowout fracture occurs. So it's not that all fractures need repair, but fractures like this, as shown in this photograph, the left eye orbital fracture definitely needs repair. So what are some indications for the fracture repair? First is muscle entrapment, a diplopia, especially in primary gaze or down gaze, an in-ophthalmos that is unacceptable to the patient or hypoglobus, or a fracture that is larger than 50% of the floor. Now, the timing of the fracture repair, generally we can repair in the first 2 weeks when the edema settles down. And sometimes we have to do an immediate repair when there is oculocardiac reflex or a trapdoor fracture. So there are various implants that have been used over the time for fracture repair, ranging from autologous bone to bioresorbable implants like the osteomesh, that is polycaprolactone. And now the non-resorbable implants, that is our titanium mesh, porous polyethylene, and a combination of these two. So the titanium mesh is now the gold standard in orbital fracture repairs, and it has got a lot of advantages ranging from mechanical strength, stability, ease of use. It is well seen on imaging and it has excellent biocompatibility. But there are certain disadvantages. One, that is permanent, and second one, it can lead to orbital adherence syndrome. So what do we do when a patient of orbital fracture repair presents with persistent diplopia that won't go? So in my case, the patient had persistent diplopia and lid retraction. Let's focus on the diplopia part. So basically, it can result from neuromuscular trauma, for which we can't do much. And the other causes are incomplete repair, so there might be still entrapped tissue, or there can be adherence of the implant material and the orbital tissue leading to orbital adherence. So it was first reported in 2009, where they reported 10 cases of orbital adherence syndrome, secondary to titanium mesh implant, and they were treated by implant removal and replacement with another implant, that was the supramesh. Orbital adherence syndrome. In orbital adherence syndrome, the irregular large pored titanium mesh is implicated. Titanium forms a thin oxide film when exposed to air. And this oxide film leads to fibroblast proliferation and inflammatory cell proliferation around the titanium mesh, leading to the most common symptoms, that are lid retraction and diplopia. The most common extraocular movement restrictions are seen, which is elevation and depression. So now, since this is an uncommon condition with no clear-cut consensus on the management, it should be detected early. It is best when it is detected early. It can be treated by implant removal, especially if there is a positive forced duction test, and it can be replaced with a smooth surface orbital implant, preferably of a different material. These are my references and my acknowledgements. Thank you.
Thank you, Dr. Parinita. I think we can open the discussion. If anybody has any questions or any points to add to this.
Yeah, this orbital adherence syndrome, it's a very interesting topic, because so far we have learned that titanium is inert, but we have seen this very commonly now, especially when we are doing resurgeries. So only 2 or 3 points that I have to add in this is, number one is the pore size. Okay, so there has been a lot of evolution in the designing of the titanium implants, because the pore size matters. Now the current 3D implants have pore sizes less than 200. So anything less than 200, they have done studies on skin fibroblasts and various other tissues and found that smaller pore size resists the fibroblast. But still, in the pre-contoured also, I have seen orbital adherence syndrome, and we have documented it, and we have presented this series in Episopus this time. So the solution to this is when you have a mesh inside the orbit previously, like you had, and you have to replace it. When you replace it, it's better to have a titanium coated one, like a Titan implant, which has got a Medport coated titanium. You're lucky in this case that it has not adhered again, but it's very common for you to have increased fibrosis because the surgery itself triggers a fibrotic reaction. That is number one. Number two is whenever the patients have a rim implant, rim plate, like we get patients in whom you get diplopia because of adherence and the rim plate is existing. That also triggers increased inflammation because the surface irregularity is one of the trigger factors for inflammation. So in these cases, if the fracture is healed, you can remove off that plate. That also reduce the chances of recurrence of lower lid retraction. Lower lid retraction and this restrictive diplopia both are a result of these kind of orbital adherence. And it is seen more often in very young patients like you had, 21-year-old. They're typical. These are very typical cases. And so nowadays, when the patient comes with very severe fracture, and if he's a young patient, I really counsel for a coated implant. The another option is one of the patients whom we run an exchange, he could not afford a covered implant, a Titan implant. So we have put a Medport sheet on top and sutured the Medport sheet to the titanium so that you have a smooth surface. But you should use 1 millimeter or less thickness of the Medport implant, because if you have a thicker one, you will get a hyperglobus. A very thin one just as a barrier. Okay, very nice, very good case. Yes, yeah. You also had a lower lid retraction remaining in this patient.
Yes,
yeah. So what I would have done is just a retractor release.
So now actually I basically have called him, but the thing is he's happy with the appearance. So would you recommend that I should have done the retractor release in that setting only, or should have waited and see?
Nowadays, if the patient comes with trauma who has been repaired previously, I tell them your solution is not one stage procedure. Okay. You will need multiple stages, but finally we'll get you to the right position. This is how I counsel on day one when I see a patient where I'm going to revise the surgery. Okay, it is best to do it in 2 stages. That is what you have done, what you have said correctly. The eyelid as a second sitting and the bone repair first. But if the patient is from out of station, you feel he is from out of country, cannot come, then you can at least release the retractor instead of putting a graft. Graft may not be needed, but at least release of the retractor helps in some situations like this. You have just a 1 millimeter retraction there. It's not severe.
So, ma'am, previously he had the incision was subciliary. Next time when I took a subconjunctival incision. So the lid retraction, have you seen it with like subciliary incision more commonly? Anything like that?
Not very common, but here you have seen it. So what happens is when they go subciliary also, the deeper dissection is in multiple planes. Other people do it. See, usually infraciliary is done by plastic surgeons or by the fasciomax surgeons, where the planes are just not recognized. So it is as good as taking a posterior approach because the septum is gone, the lower lid retractors are gone. So in that case, retraction can happen theoretically. And you did the right thing by not going through the same approach and doing conjunctival approach.
Yes, ma'am.
Any other questions? Like I have tried even mitomycin C for these patients. Like when I release the muscle, what happens is that fat cushion between the inferior rectus and the mesh is lost, right?
Yes.
When you put a mesh there. When you go back to dissect that case, it is quite difficult and it is possible that you will damage some of the fibers of the rectus. Okay.
Yeah, I was apprehensive. I thought maybe it will not improve the diplopia and all that. But thankfully,
you are very lucky. I'm telling you, it's very common to have a persistent diplopia. And in that case, what I did for few cases is I put a PRF membrane in between.
Okay.
So rich fibrin membrane, like you can collect the blood of the patient initially itself when you start the case. And process the blood till the time you finish the surgery. You will get a membrane and just put the membrane there. So it will give you growth factors also. It will reduce the fibrosis and also act as a barrier for some time.
So between the muscle and the implant, you place that one. Okay. So how common is it to see, like, after the repair, the secondary repair, again they have diplopia?
Very common.
Persistent.
That's what I'm telling you. You're very, very lucky. It is extremely common to have persistent diplopia, and we have to do some strabismus correction. Yours is because they have gone skin approach, it is little better. Some of the cases when we revise where they have used a conjunctival approach previously, even the conjunctival scarring is a contributor to the restrictive diplopia.
Okay.
You have not scarring, you have conjunctival scarring, you have your the sheath of the muscle which is scarred, as well as all the other scarring. So it's very bad restrictive diplopia in these patients. Any other questions?
Dr. BPM, Dr. Shahid, do you have any points to add?
Yeah, nice case, Parinita. Nicely managed. I don't have any points to add.
Wonderful, very interesting case, and I think it's a challenging case as well to identify the cause for the restrictive pathology and address it. Many times it is not just the implant also, it is also because of a muscle injury or an avulsion. So dynamic MRI which you have done has helped you in identifying the cause for the restriction of movement. So that is a wonderful thing. Not many centers, in private it is definitely available, but in a government setup, there are still places where they don't do dynamic MRI, and that makes a huge difference in identifying the cause and addressing it.
I actually had to send him outside to a separate center to do the dynamic MRI.
Oh, that's a wonderful thing that you took that extra step to get it done and not just take the easy way. And the one thing I have is it's just a doubt that I want to put across to the other panelists. So when we do a second, not a re-surgery, but a secondary repair where the orbit has been left unrepaired for many months and the patient presents to us maybe a year later, again there is a lot of fibrosis between the sinus mucosa and the periorbita. So while releasing the mucosa and the periorbita, sometimes you might have to use a bipolar cautery to release them because they're so fibrosed. And in that process, you might injure the periorbita and there can be fat prolapse. And I feel that also adds to a significant amount of inflammation and fibrosis to set in. And so in such patients, how do you handle it? And also second thing, the PSIs, if at all you plan for a patient, what is the size of the pore that you specifically tell the company people to keep it? The minimum, the maximum size of the holes or the pores?
Yeah, regarding that bipolar cautery thing, whenever we do this repair, it is difficult to find the correct plane. So I keep some amount of soft tissue around the inferior rectus. Don't dissect absolutely touching the inferior rectus. So if you have some of the fibrous tissue even from the sinus or whatever, you should have a cuff around the inferior rectus and always tag the inferior rectus and pull the whole globe with the cuff. So then you can go really deeper and then keep dissecting with your bipolar. Once all the tissue is released, then whatever you feel is infective or is a sinus mucosa which you can release. But never go near the inferior rectus. Most of the time, that is the problem and you will damage the muscle. That is one. Second, PSI, I don't like to use titanium PSI in the floor mesh because our Indian PSIs, I have found lot of orbital adherence. So what I do is plan the case in such a way that you do the rims well with a PEEK implant. PSI is very good. It really holds well if you have a good soft tissue cover and you don't have very scarred soft tissue. And then once your rim is in place, usually this 3-dimensional 3D regular implant fits in well. Even if it doesn't fit in well, you have residual 1 or 2 millimeter enough, but at least you don't land up with orbital adherence. Now, one of the patients whom I really needed, because 4 times she was operated and she needed PSI titanium for the floor and middle wall. That one I got a KLS Martin because I feel the surface polishing is very important in PSI. The kind of PSIs that we are getting, it really triggers a lot of fibrosis. So all our initial cases have come back with restrictive diplopia, the ones where we have used a PSI titanium.
And
Or what you can do is a PSI titanium, if you're taking, then you at least coat it with Medport.
okay. Got it. But cases where you absolutely don't have a posterior ledge to support your conventional pre-contoured implants, then what do you still go ahead and get a PSI done, or what?
You don't need a posterior ledge if you have a proper. What we are doing is, if you have a rim in correct place, it's going to rest quickly. Okay. Usually the orbital contents are not that heavy to sink in the pre-contoured implant.
So like a cantilever, it should hold.
The main thing is the angle between the floor and the medial wall. That angulation, I do it on a model. So the 3D model that we get, I realize it, ETO it. And then on table, you pre-contour correctly your floor medial wall contouring. That if it is in place and if your rim is in place, your pre-contour is okay.
Even there's absolutely no support posteriorly, you don't require a PSI.
It rests. At least with my experience with the current PSIs from various companies in India I've tried, they really trigger a reaction.
Okay.
So I'm really skeptical about using that.
Okay.
Yeah, so if you don't have a support, use a thinner implant, thinner one, so that they don't sag down. Just to support, just to provide a barrier.
Okay.
Right. Thank you for the wonderful points. Should we move on to the next case now?
Okay. And with sponges or inject?
Sponges.
Okay. Thank you.
All right. Next we have Dr. Shebin Salim. And you can share your screen, Shebin.
Thank you, Ritika. I will share my screen. Thank you, SN team, for this opportunity. So this was a very first time presentation for us. We were seeing a case like this first time. So this was a 5-year-old girl who presented with complaints of recurrent episodes of right eye discharge, pain, redness, watering, irritation, foreign body sensation since the past 3 years associated with the ulceration of the periocular skin. So her visual acuity in the right eye was 6/12, left eye was 6/6. She was very uncooperative for examination, but somehow we could see there was a grade 3 entropion in the lower lid and some cicatricial changes in the fornix. And here we can see these these ulcerative lesions on the periocular skin, which are hypopigmented in the center. So she was on treatment with topical antibiotics, topical steroids since past many months without any improvement, and we couldn't also do a proper examination. So we directly went ahead with an examination under anesthesia, along with the lower lid entropion correction with mucous membrane grafting and a biopsy of the conjunctiva and periocular skin. So here we can see that this is the biopsy of the conjunctival specimen. So here we can see there is a separation of the collection of inflammatory cells in the subepidermal region and minimal fibrosis. And this is that of the skin. Here we can see that the skin basal cells are showing damage and cleft. So the initial diagnosis were one possible diagnosis are lichen planus, discoid lupus erythematosus, and possible pediatric ocular cicatricial pemphigoid. So we started her on topical and systemic steroids, oral steroids at a dose of 20 milligram per day, weekly tapering dose. And here we can see that by 1 month follow-up, eye is quiet, the entropion is well corrected, and the periocular lesions are also healing. But what happened is she was actually from a remote area. She was actually from Lakshadweep, so the follow-up was also very difficult. This is at 7-month post-op. She presented with the recurrence again. So previously what we didn't do is a direct immunofluorescence, because at that time we were not sure of what about the possible diagnosis also. So this time we did a repeat biopsy with the direct immunofluorescence. So in which the direct immunofluorescence of the skin was showing weak linear positivity of IgA along the basement membrane zone and suspicious focal positivity for IgG, and also C3 deposition, granular weak positivity, which are suggestive of chronic bullous disease of childhood. Sorry, I didn't say one history. The parents also gave a history of bullous lesions on the hands of the child, but only one episode which resolved by itself. And the direct immunofluorescence of the conjunctiva showed weak granular positivity of C3 along the basement membrane zone. The IgG, Ig, and IgM were negative. So this was suggestive of cicatricial pemphigoid. Now, stuck with these two diagnoses, but chronic bullous disease of the childhood, the mucous membrane involvement is possible, but this child primarily presented with the recurrent episodes of mucosal lesions, the ocular conjunctival lesions. So, the other possibility is ocular cicatricial pemphigoid. But again, pediatric ocular cicatricial pemphigoid is very rare. When we did a literature research, only like 18 or 20 cases were reported in literature till date. So the child had been sent to the rheumatologist, dermatologist, and she was started on systemic immunosuppressant, mycophenolate mofetil, at a dose of 500 milligram. Initially, it was twice daily for 3 months and tapered to once daily for another 3 months for a period of total 6 months. And we also did, once I is quiet, we also did a repeat entroplan correction with mucous membrane drafting under MMF cover. So this is at final follow-up visit, that is 2 years, after stopping the mycophenolate for 6 months without any recurrence of the mucosal or the skin lesions. So cicatricial pemphigoid is a chronic immunobullous disease where the mucous membrane, especially oral cavity, the conjunctival involvement can be seen in 70 to 80% of the cases. Nasal cavity, pharynx, larynx, esophagus, vagina, urethra, and anus can be affected. This is extremely rare in children. Childhood cicatricial pemphigoid has similar clinical, histologic, and immunofluorescence features with the adult. So the ocular manifestations include chronic conjunctivitis, progressive subepithelial fibrosis of the conjunctival fornix, symblepharon formation, obstruction of the meibomian ducts, entropion, trichiasis, and eventually corneal ulcer and blindness. So his both clinical features, histopathology, and direct immunofluorescence is important to make. Everything is equally important to make a diagnosis. So in histopathology, we can see infiltration of lymphocytes, dermal infiltration of lymphocytes, plasma cells, and eosinophils, and there can be separation between the epithelium and the underlying connective tissue. This direct immunofluorescence is very specific, which shows linear IgG and C3 deposition on the basement membrane. So what I want to highlight is the direct immunofluorescence picture is similar for both mucous membrane pemphigoid and bullous pemphigoid. So that needs to be differentiated with the clinical features. In one, there is cicatrizing mucosal disease. In bullous pemphigoid, it is the skin that is mainly affected. Indirect immunofluorescence will be positive in only around 20 to 30% of cases. So the autoimmune blistering disease, here we can see that it's a wide spectrum of disease. So we have to make a diagnosis based on the clinical features and the immunofluorescence pattern. So in direct immunofluorescence, as I already told, both in mucous membrane pemphigoid and bullous pemphigoid, we can see this linear deposition of IgA or IgG and C3 along the basement membrane zone. So in this report, this was in 2010. Here we can see that till then there was only 18 cases were reported. So the first international consensus on mucous membrane pemphigoid. So what they have suggested is because of the risk of blindness, the ocular involvement is considered as a high-risk case. Therefore, they recommend systemic immunosuppressive treatment with prednisolone, cyclophosphamide, or alternative immunosuppressive. But the problem is especially when the child is on chronic oral steroids, this can cause growth retardation. Again, if you are going for a cyclophosphamide that is recommended in severe cases, it can cause chances of cancer and infertility. So this is a study. This was published in American Journal of Ophthalmology. So where they used mycophenolate mofetil for the treatment of cicatrizing conjunctivitis secondary to ocular pemphigoid. So here we can see that the complications are 30%, but there was no serious complications were reported. Also, in another study by So et al, they noticed that they have the lowest frequency of side effects with MMR when compared to other immunomodulatory therapies. Also, they have the lowest rate of discontinuation due to side effects compared to other agents. But in what are the other therapeutic options available? In severe cases, this was for infantile bullous pemphigoid, but the same treatment can be applied for cicatricial pemphigoid also. This was with the intravenous immunoglobulin therapy. Again, another option is rituximab. And this was another case reported where they managed a case of pediatric ocular cicatricial pemphigoid with entropion with tarsal fracture. But here we can see that there was no activity for a period of 1 year. Then only they went ahead with the surgery. Thank you.
Thank you, Dr. Shebin. I think you aptly named it as a confusing cicatrix. Any inputs from the panelists?
Shebin, did the patient have any oral mucosal lesion?
So, sir, no, there was no lesion on the oral mucosa or any other mucosal surface except for the eye. And when we saw the patient, there was no skin lesions, but the mother showed us a picture of bullous lesion on the hand. And this case was primarily managed by Dr. Marian. Yeah, she's here.
So, no, because the picture, like whatever you have shown and the direct immunofluorescence, it looks more like a case of linear IgA disease, linear IgA bullous dermatosis. But whatever, whether it is linear IgA disease or pemphigoid, so what I feel that MMG should not have been done in the first place. You correctly took the biopsy, but a direct immunofluorescence should have been done that time. And once the diagnosis was made, patient should have been kept on immunosuppressant topically, systemically, but no hurry in doing an MMG, because many a times with immunosuppressants they respond very nicely, and that area of dermatosis is healed, and you don't require MMG actually in many of these cases, because in the active case if you put an MMG, like the take-up is not that good.
But sir, initially we had no clue that this could be a case of ocular cicatricial pemphigoid. We were not at all suspect. And this entropy on the trichiatic lashes were rubbing on the cornea was in a bad shape when she presented to us. So that is why we did the surgery first. Yes,
I would have taken a biopsy and given a Botox.
Okay.
Rather than doing any definitive thing in the first sitting. Yeah.
So for these psychiatrical cases, there is a very good paper by Susan Freitag in Orbit Journal, and there she has given a procedure where you are not touching the conjunctiva. What you are doing is making an infraciliary incision and tugging the orbicularis to the tarsus. And this I have tried with other cicatricial cases without touching the conjunctiva. It is a very good rotation of the lid margin. In the meantime, you can also treat your conjunctival disease with systemic therapy, and the patient will not have problem of lashes rubbing on the eye. In that procedure, what they do is they actually debug the orbicularis and then plug the orbicularis to the tarsus. Then correct the horizontal lid laxity, if any. That also, you don't touch the conjunctiva. You don't do a full LTS. You just take the tarsus and anchor it to the periosteum so that the lid is tightened. And that is a very good procedure. So I would suggest that you guys read that article and use that for any of these cicatricial pemphigoid cases. Secondly, what I feel is unilateral pemphigoid case like this, very severe. How many cases are reported like this? Have you seen in the literature? I haven't seen very often such a severe unilateral disease with nothing in the other eye.
Most of the reported cases, like whatever I read, it was bilateral presentation, and they were having systemic involvement also, like oral cavity, nasal.
Yeah. Could this be herpes? I don't know. I cannot actually accept the diagnosis of OCP here.
Yeah, diagnoses are very confusing. We were totally confused initially. Even the rheumatologists, the derma, they were not agreeing to start the child on immunosuppressant also.
Yeah. Because I haven't seen unilateral cases like this. Has anybody else seen on the panel?
I have seen, ma'am, one case, but that was lichen planus. That came out to be lichen planus.
OCP unilateral like this, so severe, I haven't seen.
No, similar case, one similar case I had seen, but it came out as lichen planus.
Lichen planus.
We had done one case with the surface department, and that was also an OCP, and that was unilateral. But the only catch was the other eye was anyways a non-seeing eye because of old drawn. So we did not go in and do anything, but clinically did not have anything else. Minimal scarring on the upper eyelid, upper palpebral conch was there in the other eye, but you cannot tell. And only one eye which was good, we actually went ahead, gave a lot of IMT, did the biopsy confirmed the diagnosis, but she did not do very well because she kept having recurrent PEDs, and again there was a contracture. So despite IMT, she didn't really do very well eventually.
They don't do well in stress.
Yes, this was the follow-up was for about a year and a half, and she was around 65 or 65 plus for sure. She was an old lady, and she had cicatricial changes. She was in fact referred by another oculoplastic surgeon in Chennai itself for the surface part of it. And after contemplating, there was no other procedure that we could have done other than MMG because the whole fornix was contracted also. It was a very advanced disease. So then how do we address that? The last option I had was just lashes, just burn off all the lashes.
That's what I was saying, that only the margin eversion will help in these patients. You don't have to touch the fornix, nothing. Just evert the margin. You read that article in Orbit Journal by Susan. And that I have now used because we have a lot of cases in Agarwal like that because Susan does all these cases. And see, so usually in the other eye you will have some amount of cicatrization, like you're also saying the other eye upper lid had line. So you but this one other eye is pristine, and this only one eye involvement is what is bothering me. So I think this one said, he suggested that you keep the patient on systemic therapy for a very long time and evert the lid margin and leave the patient without doing any big procedure on the conjunctiva.
Hi Sebin, this is Dr. Lakshmi here. Thank you for presenting this case. I think if you go back to the first slide, if you just show the slide, it looks like as if there has been some kind of a chronic allergy or a fixed drug eruption. And if you have planned something, and as Shahid said, I think a biopsy alone in the first place would have sufficed. If you are planning mucous membrane graft, I think you must have done a very careful imaging, because was there history of trauma was ruled out? Was any foreign body in the orbit ruled out? You should have done an MRI, especially if you are planning a mucous membrane graft. If you're only planning topical treatment and if you're planning only a biopsy, fine, what you did is right. But I'm very sorry, I will not be accepting this diagnosis. Common things common. I think something is amiss in this case. Can you just go back to the first slide, please?
Yes.
Clinical OCP and all in child. I feel
Yes,
Lakshadweep. Was there some kind of an injury? Was the child on a beach? Was something bitten?
No, ma'am, no sinus, no discharging sinuses there.
Yeah, and also you have now aptly put that word, sinus. So if you're attempting something, some infection, inflammation from the sinuses, supposing this is a patient from Madurai or if it's a patient from West Bengal, I will first try to think whether something like rhinosporidosis, something like that, And you go back to your slide, the histopathology slide, is there any foreign body granuloma there?
No, ma'am,
The middle slide lower down, is there something like some giant cell there with,
Per se, they reported no granuloma, but only mixed inflammatory cells.
It looks like some kind of a giant cell formation there. I don't know. something is amiss, Sabin. I think it's not a bad idea to go back and because you're going to pump the child with so much of
And if you see the
immunosuppressives. No joke, no joke.
Just one thing, ma'am. So, even if it is this, how can we explain the bullous lesion on the hand?
That's what I feel. It was there some kind of a reaction, fixed drug eruption, something else, something bit the child, some foreign body reaction. I still remember many years back treating a child from Kochi with madam. We did 3 surgeries, and I think the second surgery, even a mucous membrane graft was planted. Somebody did a very careful scan in Kerala and sent it back to us. We had done the scans. It was missed. It was a small wooden foreign body. By the time we took it out in 99 or so, there were tears in the eyes. All of us were crying on in the OT. Like it was about 3 hours. That was the third time we had already had undergone a mucous membrane grafting. And as Preeti said, maybe something minimal after controlling the surface inflammation. And as Shahid said, give a Botox at least for time being. But if you're planning something like a mucous membrane graft, I think you should be doubly, triply sure. Thank you.
Thank you.
I think the psychiatrization is so severe, we couldn't have left the child just like that. I mean, so will some injectables be helpful? Like Shahid said, Botox, but I think it was quite a thick psychiatrics, and Botox everting that late, I'm doubtful. But whether
But Preeti, can you see a pseudomembrane there?
Yes,
Kind of a pseudomembrane has formed all along like a coagulum there. Yeah.
Yes, ma'am. And also the skin reaction is very linear. They are not like vesicles. They are linear scars which we see on insect bite and then allergy, that secretions which cause an allergic reaction. So even I would think of that, but like Shebin said, he had vesicles on the arm also, on the hand also, which we can't explain in that case. Maybe injection.
How did those vesicles subside?
That was before presenting to us. Actually, they were very illiterate people also. The history taking itself was very difficult. So it subsided spontaneously, but they were also on treatment with antibiotics. So we don't know exactly.
No, we don't know whether they were herpetic. Like there was a question raised whether this was herpes.
We sent the patient actually to 2 different dermatologists, different rheumatologists. They did thorough evaluation from multi-specialty hospitals. Finally, only the direct immunofluorescence.
Okay, sorry, Preeti was also mentioning something. She was asking.
Like 5FU or steroid injection, something like that, I would try first.
Steroid injection.
You just want to stop that psychiatrization initially, and because
it looks so infective kind, how would you give a steroid injection in that situation?
It wasn't infective.
Topical would be better.
They did the biopsy and it was not infective.
They did a frozen section when we were doing the MMG. So it showed only inflammatory cells.
Yeah.
First time we were doing.
Can we give 5FU for kids? I don't know. I have not done.
Like we want to know if the child is having a recurrence again, how we should approach this.
Are you in touch with the child?
Sorry, ma'am.
Are you in touch with the patient?
We have the contact number.
I somehow feel it's not systemic. It's something local, ocular.
I think you no harm in getting a good imaging done even now. Check out like Shaddeep and all the child to put the child early into the sea, into the water. I don't know. I don't know. Some seaweed, something. We don't know.
No,
we really don't know. I just think of common things, common man. I will psychiatrician.
But ma'am, we would have
in a child.
But we would have seen the rhinosporidasis on the connector.
No, not rhino. I'm not saying rhino. I'm just saying
something different like that.
Something I still feel it's some kind of a severe foreign body granuloma or something like an infection because of something there which has triggered it. Adjacent sinuses. Insect bite or some bite. Exactly.
I've seen this kind of a reaction with a bite, but I can't explain the hand vesicles.
Ma'am, just like one doubt, if it is like an insect bite, can it cause like recurrent episodes? 3 years she had a history before presenting to us.
No, but is it a reactivation of the activity or it is just going on inflammation? Is it like it subsides and then recurs again? It doesn't subside at all.
Complete remission was not there, I think, in between the episode.
Difficult case. I mean, I don't have a complete answer to it. But if it recurs, you please put up in our group and we'll all do some brainstorming.
If it is recurrent,
Can you stop sharing the screen? Just stop sharing. Sorry, Shahid, you were saying something.
No, I'm saying if the child has a recurrence, try injecting locally 5-fluorouracil with Tricort.
Yeah, I would like to do that actually. The local injection will really help. Sometimes it will just evert the lid and you will have some thing over the whole thing. Definitely don't do another surgery on the conjunctival side. That's I don't know the
Any history of fits? Any history of fits where the child was on anti-epileptics, phenitoin especially?
No, ma'am.
That's why again I come back to that same old point of trauma. Very carefully. The child has siblings, they're all okay?
No, she was a single child.
Why are you asking, ma'am? What are you thinking of?
No, something running in the families.
Initially we thought of porphyria, but that was investigated and ruled out.
Because sometimes the fixed drug eruptions can be violent. They can cause like this, they can cause those eruptions in the hand also. And they can linger, forming an inflammation. But generally, by the time, if they come in the acute stage, fine. Otherwise, you will see some pigmentation there, which has already set in alongside the orbicularis. And they come once in a few days, just like this blepharocolysis and things like that. So, I don't know. Somehow, I feel, imaging even at this stage is not a bad. How old is the child now? Less than 10 still yet?
7 years.
7,
Now
8.
she's
7, 8. A small fracture, you note down, you do both MRI and CT. There is a fracture or something, then I don't know. Should have healed by now, considering they are green stick fractures generally. But something is amiss here. I'm not, because I know how, I don't know much about you, Shevin, but I know how Marian is very meticulous and she goes through all the nuances because we have some patients in common. But I think only take-home point from my end, if you're planning something so drastic, kindly investigate properly before you put a graft. Okay, that's it.
Yes, thank you.
I had a patient who presented with similar skin lesions. The conjunctiva was not very much involved, but the skin lesions were typical hypopigmented plaques along the lid margin, and it was but bilateral. And she was an elderly patient, 60 plus aged, and she was a known CA breast, operated and then underwent chemoradiation, and then she developed systemic meds, and she was on palliative chemotherapy. And I thought maybe it's the chemotherapeutic drug that has caused these kind of skin reactions. Then we in fact discussed with the medical oncologist and stopped the medication, but still it persisted. Then we went ahead with the biopsy and it turned out to be a DLE, discoid lupus erythematosus.
But that was older people.
Bilateral involvement, but I've never seen a unilateral involvement, especially like this, with such severe mucous membrane, and especially when the oral cavity is spared, oral mucous membrane is spared, and only with eye involvement.
When you do MRI and then you just keep injectables and try to just do a 5-FU and Tricort and wait, and then if you have to do surgery, you do the skin approach. That's all we can do for this child, I think. How is the
Preeti, you combine 5-FU and Tricort, is it?
No,
single unit.
I usually like 5-FU only. I don't even give Tricort because it causes depigmentation and rise all the things. 5-FU alone is very good for psychiatrics, but I am not sure of the safety profile in kids. I have not used it in such a small. But I think you would just hope and pray that it doesn't recur.
The last follow-up was this year, March. She was doing well.
She's still on immunosuppressants?
No, she's off immunosuppressants.
How long you gave mycophenolate?
6 months.
Yeah, that is the minimum that you need. Diagnosis is a problem here, I think. Primary diagnosis, we are lost. And immunofluorescence also, I think it's not a very specific thing of OCP. Only 50% of them have positivity. It's not a very specific sign. Only clinically you have to see, combining all the other symptoms. But clinically it doesn't look like OCP actually. I would still say reaction.
Yes, ma'am.
I would still go, my first treatment would be local allergic reaction. Some trigger factor is still there. So like ma'am said, you need to do an MRI and check. Because something which is going on for 3 years, you're saying, right? 2 years or 3 years?
3 years when she was.
Yeah, people have to be still there.
I have a question pertaining to adult OCP. So what I wanted to ask is, if we are suspecting OCP, generally these patients are already on topical steroids and all. So before doing the biopsy, should we stop this topical steroids, and for how long?
No, we don't need to stop the steroids, and we need to take the biopsy from the right place, wherever it is active. So if you see the disease more in the fornix, you must take from the fornix and take very small biopsy, because anyways these people have shortage of the surface. So don't try to take too many biopsies from too many places, but the place where you suspect the activity, from there you must take. And don't put it in any preservative. It is sent just like that. So usually I call them, in Apollo guys are doing it here. So we call them and then just send the specimen in a gauze.
And there is a chance that it can come negative, no?
Yes, 50% is negative. That's what I was saying. We can't rely on just direct immunofluorescence for OCP diagnosis. But they have done the entire battery of tests, no? And they have shown, you guys have shown IgA and CD3. Any other input, Vipasha?
I think she's
in the operating.
Yeah, she's in
Did the first biopsy itself diagnose OCP?
That is one of the differential diagnosis. When she had a recurrence, we repeated the biopsy. That time we didn't do direct immunofluorescence because we were not suspecting.
So second time you suspected it?
Yeah, second time, because the first time the histopathology suggested the scarring, the possibility of OCP. So second time we did the direct immunofluorescence.
You can maybe get a second opinion from KK sir on the slides. Did you do that, Marian?
Yeah, I was about to suggest that.
I think you can discuss with him the case.
Marian, I think you're on mute.
He's actually interested in dermatopathology, no? So we had a good discussion. Yeah, he's like bullous diseases versus OCP, very difficult to comment.
But the treatment remains the same for both.
Yeah, more or less the same.
Yeah, so we don't really need to rack our brains on that.
Yes.
What we need to do is like at least treat, if basic, if it is pemphigoid, then you know how to treat it. It is a cicatrizing disease for us, and we as oculopathologists only treat that, no? But systemically, for everything, it is steroid and immunosuppressants.
Yes. But here the challenge was like in a pediatric patient, like, they were not very willing to start immunosuppression. That is why actually she got a recurrence. I was expecting recurrence in her because nobody was willing to start the immunosuppression. And I cannot keep the child on long-term steroids also.
Yeah.
So finally, when we got the recurrence, like I told, you have to start. Otherwise, I will start. So,
no, I'll send you that paper. On
I have read this article, this Susan Prater article, but I wanted to know what is her long-term follow-up.
So she has done a follow-up on, I think, 2 of the cases, 5 cases she has presented in that series. 2 of them were long-term follow-ups. I remember. I don't remember it very well. But I found that the technique is really good.
Yeah, technique
because is that margin to rotate. That's all. You don't bother about the height of the eyelid. You don't need to. Even if you have fornicel shortage, you have similar form, doesn't matter.
But actually,
all you need is to and leave the patient.
Yeah. So the thing is like, what I have seen is like in majority of these OCP cases, the tarsus will be stuck to the conjunctiva and the patient looks down, this lashes starts rubbing on the cornea. In such kind of cases, this Freytag technique will work or not, I don't know.
Why would it work? The entire margin is rotated in that nicely.
Okay.
Why wouldn't it work? So I think that is a perfect solution to this problem.
Yeah, it's better not to touch conjunctiva in OCP patients, ideally.
No, but this we have tried the skin approach. It doesn't work, no. But this particular thing is working because I've tried it in few patients.
Yeah. So you.
Sorry for asking this question. Was a conjunctival swab done when he came in first for culture and sensitivity?
No.
Why are you asking?
Kindly. Infection.
Trachoma. We thought of trachoma.
No, not trachoma. Overall infection. Trachoma will not be unilateral. Some sign will be there on the other side also.
Going on. 3 years it is going on, no?
Infection, chronic infection, fungus, KOH mount. There was some, it looked little discharge. There was some pseudomembrane also, no?
But it is
some discharge was there, I think, initially.
TB
really nice. First time I am coming across such a thing. Very, it's like an eye opener. This case.
I had a child like this bilateral, and the child did not open the eye for 3 or 4 days. That was a drug reaction, and 1 week's time, the entire eyelid was stuck to the surface. The entire cornea was keratinized, and she had lung fibrosis. We could not give VA also. We just did examination under sedation. Very bad it was. So I feel something like that it is. Very rapidly it cicatrizes.
Okay. Very nice. Keep us posted about the follow-up, Marian.
Yes, ma'am.
They were very interesting cases and we had a nice discussion. Thank you, Dr. LM ma'am, for joining in and adding your, giving us your inputs. I'd like to request Dr. SRB ma'am and Dr. Mona Khurana ma'am to now take over and with the concluding remarks, please.
Very, very interesting cases, and the discussion was also learned so much, really, especially LM ma'am's remarks and all, and Preeti, very, very nicely discussed case. I think now Dr. Mona Khurana will sum up for everybody quickly. She always does. She gives a brief synopsis. You please check. What she's saying is, it's that we have learned it correctly, whatever you've taught. Yeah. Mona, please go ahead.
Thank you, SRB ma'am. It was wonderful listening to the interesting cases and the excellent discussion. So I'll give a brief summary. Please add on to it if you want. So we went from, in the first case, which was presented by Dr. Parinita, we went from one mesh via a mesh to another, courtesy jugaad, which is very common in India. It's where the cranial mesh was used for the orbit. So post-RTA repair, managing the patients with the diplopia or lid retraction, which is persisting, can be very challenging and is usually recurrent. Dr. Parinita was very lucky in this case. So what we learned from the discussion, it's good to remove it and replace with material which has a smoother surface and a different material. It may be a coated titanium or coated with Medpor, or which should be thin, something with less number size holes. And PFS is another option which coats as well as decreases the fibrosis. And it's good to remove any orbital plates, rim plates, which if the healing has occurred. And fibrosis is definitely an enemy everywhere in all subspecialties, I would say. So a thin, smooth surface and a good dissection. And here, what was suggested, what instead of going via the skin, you should go via the subconjunctival incisions, which helps. Whereas going on to the next case, which is on childhood ocular cicatricial pemphigoid. The diagnosis can be challenging and confusing, especially if it is unilateral, because the disease is usually bilateral, even maybe asymmetrical. So always, as Dr. Lakshmi pointed out, look for another cause, a more common cause, and like viral or a drug or an insect bite or something related to the local environment of the patient. And initially, don't rush in for the surgery. Initially, it's good to go do a good clinical judgment and take a biopsy and from an active area, even though it may come negative 50% of the times, and then good to treat initially with mycophenolate at least for 6 months, and can give Botox as Dr. Shahid suggested. And only if it doesn't resolve, should go in for surgery. And here, should not touch the conjunctiva in contrast to the previous case. And Dr. Susan's papers appears to be really, really popular, and the technique appears to be popular as Dr. Preeti suggested. And of course, 5FU also helps in managing the fibrosis. And imaging prior to any surgery to rule out any foreign bodies is also recommended. So I think it was a wonderful session. I learned a lot, and please do add in if I have missed out anything. It was wonderful learning from everybody.
Thank you, Dr. Parinita.
Thank you.
Thank you.
Thank you. Happy New Year.
Cameras on. I just want to take a group picture. We always do.